Good afternoon all, and thank you for the opportunity. I'll be just discussing ROP management in day-to-day practice. Just to give you a background, that we know that our country has the highest number of global preterm births, around 3.5 million per year, and we contribute around 10% of the estimated global visual impairment due to ROP in 2010. There has been estimates that around 2 lakh neonates require screening for ROP every year, and about 20,000 of infants in our country require treatment. So that's a huge number, and we need more ophthalmologists to do ROP screening. ROP management actually involves three facets. First of all is the early detection of sight-threatening ROP. For that, we should know who are the at-risk babies, when to screen, and how to follow up. And then important aspect is treatment, which is when offered timely has the best success rate. So we should know whom to refer or treat, how to treat, and how to follow up. And then a very, very important aspect is the post-treatment follow-up. And so we should be aware of what are the ROP sequelae, and a major component would be management of the refractive errors. So who are the at-risk babies? We know that in 2017, the RBSK guidelines increased the screening criteria to include all infants up to 2 kgs and gestational age less than 34 weeks. But if the child has had a stormy neonatal course, even heavier babies needed to be screened. In the recent the National Neonatology Forum in 2020 has still adopted the same, and we now we screen all infants who are less than 2 kgs if the gestational age is not known, or less than 34 weeks. More importantly, that even heavier babies need to be screened if there is any history of oxygen exposure more than 6 hours, any history of sepsis, episodes of apnea, need for blood transfusion, exchange transfusion. In the absence of reliable records, any history of NICU or SNCU admission also becomes one of the criteria to include the child for screening. When to screen, we know that we have to do the first screening within day 30 of life. For neonates who are less than 28 weeks of gestational age or birth weight less than 1200 grams, if the gestational age is not confirmed, they should be examined earlier by 2 to 3 weeks. And at least we should try to do one screening for all infants before discharge from the SNCU or NICU. How to screen? We need to dilate with half the strength that we use for adults. So it should have 2.5% of phenylephrine. Earlier we used to make them. Now a commercial available preparation is available, so it has become easier. So 1 drop instilled 2 and maximum 3 times with punctal occlusion, and wiping off the excess from the cheeks has to be given. Standard of care still remains indirect ophthalmoscopy, though the use of wide field cameras, including the indigenous ones, including the smartphones, has increased objectivity to screening. However, there have been often questions raised whether that by ophthalmologists that if you don't have a camera, is our screening still valid? Well, yes, it is valid if you have documented clearly, made a proper diagram, and made a correct and a proper diagnosis using standard terms. So the standard terms that we have to follow is the recent classification, which is the ICROP3 classification, and we should use the terms that are used in the classification. For example, we know that it is stages. Sometimes you get referral using terms such as grade ROP. There is no such term as grade 1 or grade 2. It is a stage ROP. So the staging 1 to 5, we all know it starts from a flat demarcation line, then acquires volume to become a ridge. The ridge then has extraretinal proliferation, then it is called as stage 3. When it becomes a tractional retinal detachment, it not involving the fovea, it is 4A. When it involves the fovea, it is 4B. In the recent classification, it has been accepted that the detachments in ROP can be both tractional or exudative, as was in the case highlighted before. And the stage 5 bedside classification has been incorporated to include 5A. When clinical examination, you can see the optic disc, 5B when the optic disc is not visible, and 5C when you have 5B along with anterior segment abnormalities such as posterior synechiae, shallowing of the anterior chamber, cataract, or a corneal opacity. Aggressive posterior ROP is now to be termed as aggressive ROP because it is recognized that it may be the features can be in zone 2 also. So the posterior word is dropped. The features that you more likely see the tempo of the disease, which is a prominence of the vascular features rather than the ridge, and a rapid progression to retinal detachment, a prominence of plus disease, flat neovascularization. That is when you classify aggressive ROP. Apart from the traditional 3 zones, we now have a posterior zone 2, which is an area of 2 disc diameters that is surrounding the border of zone 1, which is included in the recent classification. In our country, because of the atypical forms and heavier birth weights getting forms of ROP, we also often use the terms such as a zone half or a posterior zone 1, which is within the zone 1, wherein even the fovea is not vascularized. So you may come across these terms also. These are not standard terms, but they are often used. Then this is the term which has been described by Professor Dogra, is the hybrid ROP, where you have features of a mixture of both a staged and an aggressive ROP. You may have a semblance of a ridge, but prominence of the vascular features. That is called as a hybrid ROP. Plus and pre-plus, we know that plus for us becomes an indication for treatment. In the recent classification, to identify plus, you have to look at the vasculature within the entire zone 1, not just the small area around the optic disc. So we've let go of the terms quadrants, but we look at what are the features in the entire zone 1, and we know that it includes arteriolar tortuosity, vascular dilatation, poor pupillary dilatation, tunica vasculosa lentis. When to treat? The ETROP guidelines are still followed, and these are the indications of treatment. In addition, all aggressive ROP has to be treated. The management of ROP, we started from cryopexy, but laser photocoagulation still remains the standard of care. We now have an addition in the form of anti-VEGF therapy, and bevacizumab, ranibizumab, aflibercept all have been used. Surgery is the most recent new innovation in the form of MIVS, so lens-sparing vitrectomy and scleral buckles. But an important aspect is the post-ROP sequelae and the whole list that we need to keep in mind when we are following up these children. For laser, we need to treat as early as possible within the first 48 to 72 hours in a near confluent pattern to the entire avascular retina. And in very posterior disease, we need to delineate the zone 1 first. So these are just examples showing laser treatment. The outcome is good, and in most cases, more than 80% success rate with laser alone. Anti-VEGF is used in selected cases of very posterior disease, zone 1 or zone half, poor pupillary dilatation, severe TVL because of the rapid resolution of the acute phase and the opportunity to allow retinal vascularization to progress. However, we have to remember about reactivations and the need for long-term follow-up, which we need to be careful for with anti-VEGF therapy. So these are just examples of pre and post anti-VEGF. I'm not sure if they are visible, but and one example of a persistent avascular retina, which we need to keep in mind and which needs a subsequent treatment. So these terms have been also included in the recent classification, the reactivation and the regression. And surgical approaches for 4A, 4B, and 5 are there, and we have had good success in terms of surgery for ROP. These are few cases which have done very well after surgery. And then for as sequelae, the most important sequelae that we need to keep in mind is myopia. And those of you who are interested can go through this paper where we have shown that the ROP myopia is more often than not is non-axial. It's not an axial myopia. It's more lenticular or anterior segment changes. So that has to be kept in mind. So to conclude, timely screening and treatment can result in favorable outcomes in a majority of cases, but all children of ROP require long-term follow-up for the sequelae. Thank you.
Thank you, Dr. Deeksha, for that wonderful illustration of cases and summarized in a short time. What is the, you can say, which stage of ROP do you commonly see in the clinic, in the tertiary care hospital?
So actually, if we look at our own center, we have two sets of children who are coming. One are the inborns that which are born in our own center, and those that are referred. So in the inborns, we most commonly see the staged ROP. And most of that ROP is the one that regresses also on its own. So we do very few treatments among our inborns. But the outborns that are referred, a majority of them are aggressive ROP. And so they are the ones that mostly need treatment.
So the ones coming which are referred, are they a delay in presentation? Yes. Or why do you find that?
No, not always are they delayed presentation, though we have people, even in 2023, we have people or infants who have come who have never been screened and have presented with stage 5. But because they come from a lot of other level 1, level 2 NICUs where the neonatal care is not standardized across the country. So there are a number of factors. So the neonatal care does have a bearing on the type of ROP, and especially the zone half, posterior zone 1, probably these are the ones who are directly related to the care that is given, because we don't see that among our inborns.
And do you give anti-VEGF for all these aggressive ROPs?
No, as I just mentioned, our indications would be severe cases of zone half or posterior zone 1 and selected cases of zone 1 anterior. We don't give for, I personally don't give for zone 2 disease.
APROP or aggressive
ROP if in posterior zone 1 and anterior zone 1, not in posterior zone 2. Do laser for those.
For aggressive ROPs, you give anti-VEGF in the first go?
Yes, for those, like I was just mentioning, those which are posterior zone 1 or zone 1 anterior or severe TVL, we will give anti-VEGF as the first go and then wait and see the response to treatment, and then generally we treat only when there is a reactivation.
Okay,
only yes.
My question is, how often would you see these patients after injection? Yeah. And how long would you do? And when would you decide to go for laser?
Yeah. So again, we give injections in both the eyes on the same day. So we treat as like 2 separate patients and take all care. Then we see the child within the next 24 to 48 hours, see the response. Most first response would be dilatation of the pupil and reduction of the pus. If that has happened, then we see the child in first week and then every 2 weeks. Now every 2 weeks, if it is going fine, we keep the child under follow-up, and we treat only if there is a reactivation of the disease. Only if parents do not understand the need for regular follow-ups or are failing to comply with that or cannot come from very far, then we somehow take a decision around 50 weeks if there is still persistent avascular retina, significant, more than 2 disc areas. Even if there is no reactivation, we then take a treatment decision to do laser. But otherwise, we generally treat at the time of reactivation.
Investigation or do you do clinically?
First is clinical. So if you have made clinical photographs, you have imaging, very good. If you don't have imaging, then your clinical photographs and your records have to be re-evaluated. Return of vascular tortuosity, dilatation, and appearance of a faint resemblance of the ridge that was not there before at the vascular-avascular junction is the sign of reactivation. So that time, if that is clinical, we do have the angiogram, which we do and confirm. But if it is not there, then clinical, these are the signs of reactivation.